Imagine a teenager stumbles into a chaotic emergency room on a Friday night. I mean, their speech is heavily slurred, they can barely walk a straight line, and they look profoundly sedated, like almost slipping into a coma.
Right, which is a terrifying presentation.
Exactly. And if you're standing there, your immediate thought is probably a drug overdose, right? Maybe heroin or a handful of Valium. But the attending physician runs a quick blood test, looks at the results, and realizes the culprit isn't a drug that simply slows the brain down.
It's actually a common chemical that has completely hijacked the patient's liver.
Yeah, it's crashing their blood sugar to fatal levels. Welcome to the deep dive. Today, we have a massive stack of sources in front of us. Clinical vignettes, biostatistical breakdowns, and diagnostic rationales.
And our mission today is really to explore the absolute highest yield concepts tested on the USMLE, the United States Medical Licensing Examination.
Right. We really want to focus heavily on those high-yield USMLE topics. Because whether you're a medical student staring down the barrel of board exams or just someone fascinated by how doctors are trained to think under immense pressure, you are in the right place.
Absolutely. We are looking at the critical do not miss diagnoses and the cognitive traps that separate someone who just memorized a textbook from a true functioning clinician.
Because the test writers for the USMLE, they are brilliant at constructing scenarios that really punish superficial memorization.
Oh, they definitely are. I mean, they don't just want to know if you can name a disease. They want to see if you understand the underlying physiological machinery well enough to predict what happens when one gear breaks down.
Right.
They test the boundaries. Like if a patient comes in with 5 different compounding conditions, they want to see if you recognize that treating one symptom might inadvertently destroy a completely different organ system.
Which means before a doctor ever touches a stethoscope, they have to understand the underlying logic, like the math of medicine.
Yeah, the math is everything.
Yeah. Because if you don't grasp the statistical reality behind the tests you order or the treatments you prescribe, you are essentially flying blind. You might tell a healthy person they're dying or send a dying person home with a clean bill of health.
It is the bedrock of clinical decision-making. You really cannot interpret a lab printout without understanding the mathematical architecture that built that specific test.
So let's start with the classic hurdle we see all over these study materials. Sensitivity versus specificity. The medical school mnemonics here are sun out and spipin.
Right, the classics.
Yeah. And I think the best way to visualize this is to imagine we're trying to catch a very specific, rare type of fish in a massive, murky lake.
I love that analogy. It works perfectly. So let's look at sensitivity first. This is not a mnemonic. Sensitivity basically measures how well a test identifies the people who actually have the disease. It minimizes false negatives.
Okay, so back to the lake analogy.
All right, so a highly sensitive test is like casting a massive, incredibly fine mesh net across the entire water. Because the holes in the net are so small, you are guaranteed to catch every single one of those rare fish.
But because the net is so fine, I'm guessing I'm also dragging up a lot of garbage, right? Like old boots, seaweed, maybe some common carp. Those are the false positives.
They are. I mean, the net isn't picky at all. It just catches everything. But here is the critical diagnostic power of that net. If you drag that massive fine mesh net through the entire lake, pull it up to the boat, and it is completely 100% empty.
Then I can be absolutely certain there are no rare fish in that lake.
Exactly. You have ruled out the presence of the fish. And that is what send out means. A highly sensitive test, when negative, rules out the disease.
Right.
This is why we use highly sensitive tests for initial public health screening. Take HIV screening, for example, which is a classic USMLE high-yield topic. You absolutely cannot afford to miss a single positive case and send an infectious patient back into the community.
So you use the giant net.
Right. You use a highly sensitive screening test.
Yeah.
If the lab comes back negative, you can confidently look the patient in the eye and say, you do not have HIV.
Okay, I follow that. But what happens if the net isn't empty? Like, what if my screening test comes back positive? I caught something, but I don't know if it's the rare fish or an old boot.
You need to filter it.
Yeah, I need a way to filter the garbage from the real threat.
And that brings us to specificity, the Spenton mnemonic. Specificity is all about correctly identifying the healthy people. It minimizes false positives. It's the ability of a test to look at a healthy person and accurately say, you are healthy.
So if sensitivity is the massive net, specificity is more like a highly trained inspector standing on the boat looking at what we caught.
A very strict inspector.
Yeah.
Let's say the initial sensitive HIV screen comes back positive. We don't panic the patient yet. because we know the net catches boots.
Right, we expect some garbage.
Exactly. So we need a confirmatory test, like a Western blot, which is highly specific. If that specific test comes back positive, the inspector has verified it. We have ruled in the disease. A highly specific test, when positive, rules in the condition.
Okay, let me test my own logic here, though. Because if a test is super sensitive and comes back positive, I naturally want to think it's highly accurate.
It's a common assumption.
Right. Like, why do the sources spend so much time harping on a separate metric called positive predictive value, or P+V? Doesn't sensitivity already tell me how good the test is?
This is one of those common cognitive traps in medicine, actually. Sensitivity and specificity are fixed traits of the manufactured test. They exist in a vacuum.
What do you mean by that?
Well, a test with 99% sensitivity is always 99% sensitive, whether you use it in New York City or Antarctica.
Mm?
Sensitivity asks a backward-looking question. It asks, of all the sick people in the world, how many did this test find?
But if I'm a patient sitting on the exam table sweating through a paper gown, I don't care about the global population of sick people.
You care about yourself.
Exactly. I care about the piece of paper in the doctor's hand. I want to know, my test is positive, so what are the actual chances that I am sick?
And that forward-looking question is answered by the positive predictive value. But here is the mind-bending part. The PPV changes entirely based on how common the disease is in the population you are testing.
Wait, really?
Yes, the prevalence dictates the reality.
Walk me through how prevalence changes the accuracy. Because if the test is the exact same piece of plastic, how does the neighborhood I'm in change the result?
Okay, let's run a thought experiment. Imagine we have a diagnostic test with a 5% false positive rate. Now, imagine we decide to use this test to screen for a disease that has been totally eradicated from the face of the earth.
So the prevalence is absolute zero.
Right. The disease doesn't exist. We administer this test to 100 perfectly healthy people. Because of the 5% false positive rate, the test will flag 5 people as positive.
But we already established the disease does not exist.
Exactly. So what is the probability that those 5 positive results are real?
0%. I mean, they're all false alarms.
So your positive predictive value is 0. The test is completely useless in that environment. Now, take that exact same physical test with the exact same 5% false positive rate and walk into an infectious disease ward where 90% of the patients actively have the condition.
Okay, totally different environment.
Right. If you test someone in that ward and it comes back positive, the chance of it being a true positive is astronomical because almost everyone has it anyway. The PPV skyrockets.
Wow.
The board exams want doctors to understand that you cannot treat a lab value in isolation. You have to treat the patient in the context of their demographic risk.
You have to know the pond before you cast the net. That makes total sense. So moving from diagnosing to treating, the sources dive heavily into how doctors evaluate whether a new therapy is actually worth using.
Right, evaluating clinical trials.
Yeah, there's a detailed vignette about a study on congestive heart failure. It compares standard monthly clinic visits to a new remote patient monitoring system. And the core task for the student is calculating the number needed to treat, the NNT.
The NNT is perhaps the most practical, grounded metric in public health. It answers a very blunt question. It asks, how many patients do I need to put through this new therapy to prevent exactly one bad outcome?
And the sources are adamant that to find the NNT, you have to use absolute risk reduction, or ARR, and never relative risk reduction. Let's look at the numbers they gave. Over a 6-month period, the mortality rate for the standard care group was 15%.
Okay.
The mortality rate for the remote patient monitoring group was 13%.
So let's calculate the relative risk reduction first, just to see how deceptive it can be. Mortality dropped from 15% to 13%. That's a difference of 2 percentage points.
Right.
If you divide that 2 by the original baseline of 15, you get roughly 13.3%. So a pharmaceutical representative could legally walk into a hospital and say, hey, our new monitoring system reduces mortality by over 13%.
Which sounds revolutionary. I mean, if I hear 13% reduction in death, I want that machine immediately.
It sounds massive, but it's a relative illusion. The USMLE demands that clinicians strip away the marketing and look at the absolute risk reduction. This is the raw, unvarnished subtraction.
There's simple math.
Exactly. 15% minus 13% is 2%, or 0.02. In absolute terms, out of 100 patients, this intervention saves exactly 2 lives.
That feels much smaller. So to get the number needed to treat, you take 1 divided by that absolute risk reduction. 1 divided by 0.02 is 50.
Correct. You must provide remote patient monitoring to 50 individual patients in order to prevent one single death. That is the stark reality of the intervention.
That puts it in perspective.
It does. Because if hospital administrators only looked at the relative risk, they might divert millions of dollars from other life-saving programs to buy these machines, thinking they are stopping 13% of all deaths.
Oh.
The absolute numbers force medical professionals to allocate resources based on ground truth, not statistical inflation.
Speaking of ground truth, there's a fascinating statistical trap here regarding cataracts. The vignette describes a study that reviewed the medical records of all active-duty United States Navy personnel and compared the prevalence of cataracts to all active-duty United States Army personnel.
Oh, this is a classic trick.
Yeah, the question asks what the correct statistical measure to report is. The options give things like prevalence ratio plus or minus standard deviation, or prevalence ratio with a 95% confidence interval. But the right answer is just the raw prevalence ratio, no confidence interval attached.
Right.
My instinct is always to include a margin of error. I mean, why don't we need one here?
This is a beautiful test of conceptual understanding. To know why there is no confidence interval, you have to remember why confidence intervals exist in the first place. They exist to compensate for sampling error.
Meaning, we usually can't afford to test an entire population, so we test a smaller group and guess the rest.
Right. Like if I want to know the average cholesterol level of everyone in California, I can't draw blood from 39 million people. I take a representative sample of 5,000.
Makes sense.
But because I only took a sample, my average might be slightly off from the true state average. The 95% confidence interval is my safety net. I am saying, based on my sample, I am 95% confident the true average of the whole state falls between these two numbers.
But look at the wording of the Navy and Army study. They didn't take a sample. They reviewed the medical records of all active personnel.
The entire population. There is no sample. Therefore, there is zero sampling error. You aren't guessing the prevalence. You possess the absolute mathematical fact of the prevalence.
Oh.
Yeah, if the Navy is 4% and the Army is 2%, the ratio is exactly 2.0. Adding a confidence interval to a complete population data set demonstrates a fundamental failure to understand what a margin of error actually is. The board writers use this to weed out students who just memorize formulas from those who actually understand the philosophy of data.
It's a logic puzzle hiding inside a math problem.
Exactly.
Let's look at how multiple studies are combined. The sources break down forest plots, specifically looking at a meta-analysis on coffee consumption and endometrial cancer. The visual is a graph with a solid vertical line right down the middle at the number 1.0.
Right, the line of no effect.
And then there are all these horizontal lines stacked up representing different individual studies.
A forest plot is the ultimate bird's eye view of medical research. When you have 10 different small studies on coffee and cancer, and they all have slightly different results, a meta-analysis pools all their data together to find the overall truth.
So what happens if a line crosses that middle vertical line?
Well, if a study's horizontal line, which is its confidence interval, crosses that 1.0 line, it means the study's results are statistically insignificant. It means drinking coffee could be protective, it could cause cancer, or it could do nothing at all.
But the crucial part of the forest plot is the summary estimate at the very bottom, usually shaped like a diamond. In the coffee study, that diamond is floating entirely to the left of the 1.0 line, and the p-value is listed as less than 0.001.
And a p-value of 0.05 is the traditional cutoff for statistical significance. A value less than 0.0011 is incredibly strong. It tells clinicians that when you aggregate the global data, there is a highly significant, verifiable decrease in the risk of endometrial cancer for women who consume moderate amounts of coffee daily.
So the debate is largely settled.
The diamond doesn't cross the line, so yes, the debate is mostly settled.
Which brings us to how we measure the impact of these findings on society. There's a public health scenario here where a state government repeals its mandatory motorcycle helmet law. 3 years later, a researcher wants to evaluate the true public health cost of that decision.
A very real-world scenario.
Yeah. My first thought is simply to look at the mortality rate. Like, did more motorcyclists die? But the correct metric listed is Dale's disability-adjusted life years. Why isn't crude mortality the best way to measure the impact of a crash?
Because crude mortality is binary. You are either alive or dead. It completely ignores the spectrum of human suffering in between. If you repeal a helmet law, you might see a slight bump in fatalities. But the massive hidden iceberg is the explosion of severe, non-lethal traumatic brain injuries.
The people who survive the impact. but their lives are forever altered.
Exactly. Imagine a 22-year-old who crashes without a helmet. They survive, so they don't show up in the crude mortality statistics, but they suffer a severe brain injury requiring a feeding tube, 24-hour nursing care, and multiple surgeries. And they lose the ability to walk or speak for the next 50 years of their life.
That's devastating.
It is.
Yeah.
Mortality statistics look at that patient and say, success, they didn't die.
Mm-hmm.
Delis look at that patient and quantify the immense loss of healthy, functional years.
So disability-adjusted life years combine the years of life lost to premature death with the years of healthy life lost due to severe disability.
Right. It provides a single, comprehensive number that reflects the true burden on the healthcare system, the economy, and the families involved. It forces public policymakers to acknowledge the weight of surviving with a profound disability rather than just tallying toe tags in the morgue.
Wow. So the math proves a drug or policy works across a population, but zoom in on one specific patient, and that same mathematically perfect treatment can become a lethal weapon if you don't understand the environment of their body.
Oh, absolutely.
Let's look at the pharmacological domino effects.
This is where clinical medicine becomes an ecosystem. You introduce a chemical to fix the roof, and you accidentally flood the basement.
The prime example in the sources is a vignette of an 82-year-old woman. Let's call her Martha. Martha lives independently, has mild hypertension, and takes 2 daily medications: hydrochlorothiazide, which is a diuretic, and an ACE inhibitor.
Very standard regimen for someone her age.
Right. Her latest lab work shows her kidneys are functioning perfectly. Her creatinine is 1.0. But Martha has developed moderate osteoarthritis in her knees. She asks her doctor if she can just start taking an over-the-counter NSAA, like ibuprofen, a few times a day for the pain.
And that's where the danger starts.
The question asks what the greatest immediate risk is. And the answer is acute kidney injury. Now, millions of people pop ibuprofen for a sore knee every day. Why is it a ticking time bomb for Martha?
To understand the danger, we have to shrink down and look at the microscopic plumbing of Martha's kidneys. The functional unit of the kidney is the nephron, and the filtering component is called the glomerulus.
Okay, the glomerulus.
Imagine the glomerulus as a microscopic coffee filter. Blood flows into the filter through a tiny hose called the afferent arteriole. After the blood is filtered to make urine, it flows out through another hose called the efferent arteriole.
So we have an inflow hose, the filter itself, and an outflow hose.
Exactly. Now, for the filter to actually push toxins out of the blood and into the urine, there has to be high pressure inside that filter. The kidney is obsessed with maintaining that pressure. It has natural biochemical defenses to keep it stable.
And what are those defenses?
One of the main defenses relies on molecules called prostaglandins. Prostaglandins act to dilate or widen the inflow hose, the afferent arteriole. They essentially prop the door open so a massive volume of blood can rush into the filter, keeping the pressure high.
Let me guess the NSAID connection. NSAIDs are anti-inflammatories. They work by blocking the enzymes that make prostaglandins, right? So if she takes ibuprofen for her knee, she is wiping out the prostaglandins in her kidney too.
You've got it. Without prostaglandins, that inflow hose violently constricts. The front door slams shut. Far less blood can enter the filter. Now, in a 25-year-old who is fully hydrated, the kidney has other ways to compensate.
But Martha is 82.
Yes, her vascular system is already stiff. Furthermore, look at her daily medications. She's taking hydrochlorothiazide, a diuretic water pill.
Which means her total body fluid volume is already running low. There isn't as much blood volume to go around in the first place.
So she has low fluid volume, and she just clamped her inflow hose shut with the ibuprofen. Now, add her third factor, the ACE inhibitor. Remember the outflow hose, the efferent arteriole?
Right, the exit hose.
Usually, to keep pressure high inside the filter, the kidney keeps that outflow hose slightly pinched, like putting your thumb over a garden hose. ACE inhibitors work by relaxing and dilating that outflow hose. They open the back door wide open.
Oh, wow. I see the trap. The diuretic drained the main water tank, the NSAID pinched the front hose shut so no water can get in, and the ACE inhibitor opened the back hose wide so whatever little water is left rushes right out.
That is the notorious triple whammy. The pressure inside the glomerular filter drops to absolute zero. The kidney completely stops filtering blood. Toxins build up rapidly, and within days, Martha is in the emergency room with acute kidney injury, all because she took an over-the-counter painkiller for her knee.
That's terrifying.
The USMLE tests this constantly because all 3 of these drugs are incredibly common, and if a doctor doesn't visualize the plumbing, they will destroy the kidney trying to fix the joint.
You have to see the whole board, not just the one piece you're trying to move.
Precisely.
Let's look at another scenario where treating the immediate symptom isn't enough. We have an elderly patient rushed to the ER, drowning in her own fluids. She has orthopnea, meaning she can't breathe when she lies flat, her neck veins are bulging, and she has a murmur indicating mitral regurgitation.
Classic signs of acute congestive heart failure.
Right. So the attending gives her a massive dose of furosemide, a loop diuretic, to pull the fluid out of her lungs. She pees out 2 liters, she can finally breathe, she feels great. But the board question asks what additional medication is required. And the answer is lisinopril, an ACE inhibitor.
Another ACE inhibitor scenario.
Yeah. If the diuretic fixed her breathing, why add another drug?
This scenario cuts to the heart of modern cardiology. It's the difference between symptom management and disease modification. When a patient is suffocating from pulmonary edema and heart failure, furosemide is a miracle. It forces the kidneys to dump the excess volume.
And the patient survives the night.
Yes, but furosemide is just bailing water out of a sinking boat. It does absolutely nothing to fix the hole in the hull. It has 0 proven long-term mortality benefit.
It makes them feel better today, but it won't keep them alive for next year.
Exactly. To alter the trajectory of the disease, you need the ACE inhibitor. In heart failure, the weakened heart muscle is exhausted. Every time it beats, it has to push blood out against the systemic resistance of the body's blood vessels. This resistance is called afterload.
I think of afterload like trying to blow air through a tiny, narrow cocktail straw versus a wide boba tea straw. The heart is blowing through a cocktail straw and it's just exhausting.
A perfect analogy. An ACE inhibitor acts as a vasodilator. It relaxes the blood vessels throughout the body, magically turning that cocktail straw into a boba straw. The afterload drops, and the failing heart doesn't have to work nearly as hard to pump blood forward.
So it takes the pressure off.
It does. But the benefits go much deeper than that. ACE inhibitors block a hormonal cascade that causes something called cardiac remodeling.
Remodeling usually sounds like an upgrade. Why is it bad for the heart?
Well, when the heart senses it is failing, the body panics and floods the system with hormones like angiotensin II. These hormones cause the heart muscle cells to thicken, stiffen, and become fibrotic in a desperate attempt to bulk up.
Like it's hitting the gym.
Right. But this bulky, stiff muscle is actually terrible at relaxing and filling with blood. The remodeling accelerates the heart failure. ACE inhibitors block this toxic hormonal pathway, physically preventing the heart from destroying its own architecture.
Wow.
That is why ACE inhibitors reduce mortality. You use the diuretic to keep them out of the ER today and the ACE inhibitor to give them a tomorrow.
Let's talk about a drug reaction that is pure nightmare fuel. A 20-year-old man is diagnosed with seizures and is prescribed carbamazepine. 10 days later, he comes into the clinic. He has a fever and a rapidly spreading, blistering rash on his face and chest.
Oh, SJS.
Yeah. The skin is literally sloughing off in sheets when touched. This is Stevens-Johnson syndrome. Now, if I see a patient whose skin is peeling off like severe burns, my instinct is to rush them to a burn unit, pump them full of IV fluids, and give them massive doses of steroids to calm the inflammation.
That's a very natural instinct.
But the correct first step in management is incredibly brief. It simply says, stop the offending agent. That feels so passive. Why is that the priority over immediate burn care?
It feels counterintuitive because the visual of SJS is so horrific you want to take aggressive action. But SJS and its even more severe cousin, toxic epidermal necrolysis, are profound immune-mediated hypersensitivity reactions.
So the body is attacking itself.
Yes. The patient's own immune system has misidentified the carbamazepine molecule as a lethal invader. The immune system has essentially called in an airstrike on the body's own skin cells.
The drug is the target laser.
Yes. And as long as that drug is in the patient's bloodstream, the immune system will continue to drop bombs. You can give all the IV fluids, pain meds, and wound care in the world, but if the trigger is still being pulled, the damage will continue.
So nothing works until you stop the drug.
The absolute foundational concept of toxicology and adverse drug reactions is that you must turn off the tap before you start mopping the floor. Discontinuing the carbamazepine is the only way to signal the immune system to call off the airstrike. Once you've done that, then you transfer them to the burn unit for the intensive supportive care.
Stop pulling the trigger. That is a powerful clinical rule. Moving to a different kind of withdrawal, the sources outline a case of a 47-year-old man admitted to the hospital after a car accident. His chart notes a 25-year history of severe daily alcohol abuse.
Okay, setting the stage for withdrawal.
Exactly. 2 days into his hospital stay, He isn't drinking, obviously. He suddenly becomes extremely disoriented, starts sweating profusely, his heart rate shoots to 140, and he is batting at the air, experiencing terrifying visual and auditory hallucinations. He is in delirium tremens.
A true medical emergency.
And the board question focuses on a specific blood test. What electrolyte is he most likely missing? The answer is magnesium, hypomagnesemia. What does magnesium have to do with hallucinating spiders?
Everything is connected in severe alcoholism. Chronic alcoholics are typically profoundly malnourished. They derive a huge portion of their daily caloric intake from the ethanol itself, which means they're eating very little actual food.
Right, their diet is terrible.
Their dietary intake of essential minerals like magnesium is near zero. Furthermore, alcohol acts as a direct toxin on the renal tubules in the kidney, forcing the kidneys to waste whatever little magnesium the body has left, dumping it into the urine.
So they aren't eating it, and they are peeing out whatever they do have. But why does a low magnesium level make the brain misfire so violently during withdrawal?
Because magnesium is essentially the biochemical brake pedal for the central nervous system. It naturally blocks certain excitatory receptors in the brain, keeping electrical activity calm and regulated.
Okay, I'm tracking.
Now, think about the brain of a chronic alcoholic. It is constantly being bathed in a heavy depressant alcohol. To keep the person awake and breathing, the brain has to adapt by massively upregulating its excitatory pathways. It pushes the accelerator to the floor just to overcome the alcohol.
And then the car crash happens and the alcohol is suddenly taken away.
The heavy depressant is gone, but the accelerator is still mashed to the floor. The brain goes into a state of hyperexcitability. This is alcohol withdrawal. Now, normally, a healthy body would use magnesium to apply the brakes and calm that electrical storm.
But this patient has no magnesium left.
No brakes. Zero brakes. The electrical storm spirals out of control, leading to the severe autonomic instability, the hallucinations, and eventually life-threatening seizures.
Wow.
Correcting that hypomagnesemia is a critical step in treating the withdrawal, because you have to give the brain the raw materials it needs to calm itself down.
It's incredible how a mineral deficiency in the gut and kidney manifests as a psychiatric crisis in the brain. Before we leave pharmacology, there is a brief mention of rheumatoid arthritis.
Another high-yield topic.
Yeah. A young woman is diagnosed with RA, and the standard of care dictates she must immediately be started on methotrexate. Methotrexate is a serious drug. It originally started as a chemotherapy agent. Why are we bringing out the big guns on day one? Why not just manage her joint pain with high-dose NSAIDs for a few years first?
Because treating rheumatoid arthritis with painkillers is like putting a bucket under a leaky roof and ignoring the rotting wood. RA is an autoimmune disease where the immune system specifically targets the synovial lining of the joints.
So it's not just wear and tear.
No, not at all. It causes pain and swelling, yes, but beneath the surface, the immune cells are actively dissolving the cartilage and eroding the bone.
The abolition crew inside the knee.
Exactly. If you only give her NSAIDs, she will feel better. The pain will be gone. But the demolition crew will keep working in the dark. Within 5 to 10 years, her joints will be permanently fused, deformed, and useless.
So you have to stop the damage, not just the pain.
Right. The medical paradigm shifted dramatically when we realized we had to stop the bone erosion. Methotrexate is a DMARD, a disease-modifying anti-rheumatic drug. It dials back the immune system's attack. The USMLE wants doctors to know that in ARA, time is joint function. You strike early, and you strike hard with a DMARD to alter the course of the disease before irreversible structural damage occurs.
In all those scenarios, we generally knew what was wrong with the patient. We just had to pick the right chemical key. But what happens when the diagnostic picture is completely blank and the clock is ticking?
That's the real test.
Let's move into diagnostic triage, the classic board exam prompt. What is the next best step in management?
This is where clinical algorithms are born. It's not enough to list differential diagnoses. You must know the exact sequence of tests that will prove the diagnosis safely without wasting time or resources.
Let's start with a high-stakes cardiac case. A 62-year-old woman arrives in the emergency room clutching her chest. The pain is crushing, radiating to her jaw. She has a history of type 2 diabetes and high blood pressure.
Textbook ACS presentation.
Right. They give her nitroglycerin under the tongue, but the pain doesn't budge. They hook her up to an ECG machine, and it shows a new left bundle branch block. The nurse draws blood to check her troponin levels, which is the main biomarker for a heart attack, and the troponins come back completely normal.
Okay, the plot thickens.
The question asks for the next step. The options include an exercise stress test, a nuclear perfusion scan, or cardiac catheterization. The answer is to rush her to the cath lab. I have to push back here. Her troponin blood test is normal. Doesn't that scientifically prove her heart muscle isn't dying? Why are we rushing into an invasive surgery?
You've fallen into the classic timeline trap. To understand why her blood work is normal, you have to know what troponin actually is. Troponin is a structural protein locked deep inside the heart muscle cells. It only leaks into the bloodstream when those cells rupture and die from a lack of oxygen.
Okay, so if the cell dies, it spills its guts and we measure the troponin.
Right. But that cellular death and the subsequent sculling of proteins into the blood takes time. It can take anywhere from 3 to 6 hours after an artery gets blocked for the troponin levels to rise high enough to trigger a positive lab result.
Oh, so it's not instantaneous.
Not at all. This woman's crushing chest pain started 45 minutes ago. Her heart muscle is actively suffocating right now, but the cells haven't massively ruptured yet. Her troponin is normal today, but if you wait 4 hours, it will be sky high.
Okay, but if the blood is lining to us, how do we know for sure the artery is blocked?
We look at the electrical wiring. The heart has a massive electrical highway system that coordinates the pumping. The left bundle branch is the main highway that delivers electricity to the massive left ventricle, which is the primary pumping chamber. And the ECG shows a new left bundle branch block.
The highway just got washed out.
Exactly. And what washes out an electrical highway in the heart? A massive lack of blood flow. In a patient with active crushing chest pain, a brand new left bundle branch block is treated as the clinical equivalent of a STEMI, a massive acute heart attack. It is an absolute emergency.
So why not do a nuclear stress test just to be 100% sure before cutting into her artery in the cath lab? The sources say nuclear tests check for perfusion, right?
They do check for perfusion, but they take hours to set up, inject the radioactive dye, and scan the patient. A nuclear stress test is strictly for stable patients.
Define stable.
Like if a guy comes into the clinic and says, "My chest gets a little tight when I walk the dog, but I feel fine right now." You use a nuclear scan to hunt for subtle, stable blockages. But this woman is unstable. She's having an event right now. You don't waste time looking for the blockage on a scan. You take her straight to the cardiac catheterization lab, where a cardiologist can thread a wire up to the heart, find the blockage, and immediately deploy a stent to open the artery. Diagnostic and therapeutic in one swift move.
Time is muscle.
Always.
Let's pivot from the heart to the bones, specifically pediatric oncology. A 15-year-old boy has been complaining of progressive deep pain in his lower thigh for months. An X-ray shows a horrifying image. The bone looks moth-eaten, and there's a sunburst pattern of new bone violently reacting to a mass.
Classic osteosarcoma presentation on an X-ray?
Yeah, the suspicion is osteosarcoma, a highly aggressive primary bone cancer. The question asks for the next diagnostic step to confirm. The answer is an open biopsy. Let me ask the obvious question. If we want to look at the mass, why not just scan his leg with an ultrasound first? It's painless, cheap, and has zero radiation.
Because in diagnostic triage, a test that provides zero useful information is a dangerous delay. Ultrasound technology relies on sound waves bouncing off tissues. It is phenomenal for visualizing soft, squishy things like a cyst in the liver, a baby in the uterus, or a blood clot in a vein.
But bone is dense.
Sound waves cannot penetrate solid cortical bone. They just hit the surface and bounce right back. The X-ray has already proven that the tumor is originating inside the medullary cavity of the bone itself.
So the ultrasound would just show the outside.
Exactly. Running an ultrasound wand over the kid's leg will only show you the healthy muscle and fat on top of the bone. It will tell you absolutely nothing about the internal architecture of the cancer. It's a waste of critical time.
Okay, skip the ultrasound. But why an open biopsy? That means taking him to an operating room, putting him to sleep, and cutting his leg open with a scalpel. Why not just take a needle, poke it through the skin, and suck out a tiny piece of the tumor?
This requires thinking like a surgical oncologist. Osteosarcoma is incredibly aggressive. If you simply stab a needle into that tumor and pull it out, you create a microscopic tunnel, a biopsy tract. As you withdraw the needle, cancer cells can easily wipe off and seed themselves all along that tunnel, contaminating the healthy muscle and skin.
Oh man, you're spreading the cancer just by trying to diagnose it?
Precisely. Because of this high risk of seeding, the definitive surgery, which will happen weeks later after chemotherapy, must include cutting out the entire bone tumor and completely excising the entire biopsy tract.
That makes sense.
Therefore, the biopsy cannot be done haphazardly by a random doctor in a clinic. It must be meticulously planned, often as an open surgical biopsy, by the exact same orthopedic oncology team that will perform the final limb salvaging surgery. They need to know exactly where the tract is so they can safely remove it later.
The diagnosis has to be integrated with the surgical cure from day one. Let's contrast that with another mass. A 50-year-old man has a painless, progressively growing mass deep in the soft tissue of his thigh. The suspicion is a soft tissue sarcoma.
Okay, a soft tissue mass.
The next step here is not an open surgery, it's a core needle biopsy. Why is a needle okay for the muscle but not for the bone?
For a soft tissue sarcoma, a core needle, which is a thick, hollow needle that punches out a tiny cylinder of tissue, is usually sufficient to grab enough cellular architecture for the pathologist to make a diagnosis.
And it doesn't spread it.
It's guided by imaging, it's less morbid than an open surgery, and while tract seeding is still a slight concern, it is far less critical than in aggressive primary bone cancers. The core needle provides a massive chunk of tissue compared to a fine needle.
Which perfectly leads to my next scenario. A young woman has a painless lump in her neck. Her thyroid hormone levels are normal, but ultrasound shows a solid, suspicious nodule in the thyroid gland. The next step is a fine needle aspiration, or FNA. We went from a scalpel to a thick core punch to a tiny, thin needle. Why is the smallest needle the winner here?
It's all about the anatomy of the organ and the statistical likelihood of cancer. The thyroid is incredibly superficial. It sits right under the skin of the neck. It is also highly vascular, meaning it bleeds easily if you use a thick needle.
So a big needle is dangerous there?
Right. More importantly, the vast majority of thyroid nodules are totally benign. You don't need a large architectural chunk of tissue to rule out cancer in the thyroid. You just need to suck out a few loose cells, smear them on a glass slide, and look at their nuclei under a microscope. An FNA is fast, it can be done in the office in 5 minutes, the complication rate is near zero, and it provides exactly the cellular data you need.
Match the weapon to the target. Let's move to the ER for a completely different kind of triage. A 52-year-old woman arrives with fever, severe right upper quadrant abdominal pain, and jaundice. Her eyes and skin are turning yellow.
The classic biliary triad.
The critical piece of history is that she had her gallbladder removed, a cholecystectomy, 7 days ago. Her blood work shows a massive spike in bilirubin and alkaline phosphatase. The next step in management is an ERCP, endoscopic retrograde cholangiopancreatography. First, what does alkaline phosphatase tell us, and why is ERCP the answer?
Alkaline phosphatase is an enzyme that lines the bile ducts in the liver. When a bile duct is physically blocked, that pressure builds up and the cells release large amounts of alkaline phosphatase into the blood.
Okay, so it's a pressure gauge.
Exactly.
Yeah.
Combined with the jaundice, which has built up bilirubin, this lab profile screams that there is a severe plumbing blockage in the biliary tree.
But she just had her gallbladder taken out. Shouldn't the plumbing be fixed?
A cholecystectomy is a very common surgery, but it requires the surgeon to cut and clip the small duct that connects the gallbladder to the main biliary highway. Sometimes, a tiny gallstone escapes during the surgery and rolls down into the main duct, blocking it. Or a surgical clip slips and bile starts leaking into the abdomen.
So how does the ERCP fix it?
It is a marvel of gastroenterology. A doctor passes a long, flexible endoscope down the patient's throat, through the stomach, and into the duodenum, which is the first part of the small intestine. They locate the tiny sphincter where the bile duct empties into the gut.
Sounds intense.
They thread a microscopic catheter up into that duct and shoot X-ray dye backwards into the liver to see exactly where the blockage or leak is.
That's the diagnostic part.
And here's the therapeutic magic. If the X-ray shows a retained gallstone blocking the duct, they can deploy a tiny wire basket through the scope, grab the stone, and pull it out into the intestine. If they see a leak from a slipped clip, they can deploy a plastic stent across the hole to seal it and allow it to heal. They diagnose the postoperative complication and physically repair it from the inside out, all without making a single incision on the patient's skin.
Diagnose and cure in one breath. But you can't always trust the surface picture. Sometimes the body actively lies to you.
Oh, the masqueraders.
Yeah, the USMLE loves to present scenarios that look like one disease, but are actually driven by a completely unexpected, hidden mechanism. Let's look at Section 4, the Great Masqueraders.
These require deep metabolic thinking, because if you treat the surface symptom, you will kill the patient.
Let's revisit that teenager from our opening hook. The 16-year-old brought into the ER stumbling, slurring their words, acting heavily intoxicated. The obvious suspects are drugs, heroin or diazepam, which is a benzodiazepine.
Right, the usual suspects for a sedated teen.
But the blood glucose monitor beeps and the sugar is 35 milligdl. Normal is closer to 100. The expert breakdown says this severe hypoglycemia rules out the drugs and definitively points to acute alcohol intoxication. Why? Don't drugs make you pass out too?
They do, but they have distinct physiological signatures. If the teenager had overdosed on heroin, an opioid, we would see the classic clinical triad: profound coma, severely depressed breathing, maybe 4 breaths a minute, and pinpoint constricted pupils.
And what about the benzo?
If they took diazepam, a benzo, they would be sedated and clumsy, but their blood sugar would be perfectly fine.
So how does drinking too much vodka crash a teenager's blood sugar to 35?
It's an incredible biochemical hijack. The liver is the body's metabolic factory. When you haven't eaten in a while, the liver performs a critical task called gluconeogenesis. It literally builds new glucose molecules from scratch using amino acids and lactic acid, pumping that sugar into the blood to keep the brain fed.
The factory's building cars.
Right. But this process requires a specific helper molecule, an enzyme cofactor called NAD+Lr. When a massive tidal wave of ethanol hits the liver shifts entirely into panic mode to break down the poison. The enzymes that metabolize alcohol rapidly consume almost all the available NAD+ in the factory.
Like a toxic spill happens on the factory floor, and management pulls every single worker off the assembly line to clean it up.
Exactly. Because there is no NAD+ left, the gluconeogenesis assembly line grinds to a complete halt. The liver stops making sugar. Adults have large reserves of stored sugar called glycogen that they can release to survive this. But teenagers and young children have very small glycogen reserves.
So they run out fast.
They deplete them quickly, and without the factory making new sugar, their blood glucose plummets. The slurred speech and stupor aren't just from the alcohol sedating the neurons, they're also symptoms of neuroglycopenia. The brain is literally starving for energy.
That is a brilliant trick of physiology. Let's look at a reproductive masquerader. A 24-year-old woman comes to her gynecologist complaining of heavy, disruptive uterine bleeding. The crucial detail in her history is her cycle length.
The timing is everything here.
Her periods are wildly irregular, arriving anywhere from 45 to 70 days apart. A physical exam is normal. The differential diagnosis essentially comes down to a structural problem, like a leiomyoma, a benign fibroid tumor, versus a hormonal problem, specifically a novulation, where the ovary fails to release an egg.
Right, structure versus hormone.
The USMLE answer is a novulation. But don't fibroids cause heavy bleeding?
Fibroids absolutely cause heavy bleeding. But the diagnostic key lies in the calendar, not the volume of blood. Pattern recognition is everything. If a woman comes in with massive bleeding, but her cycles are perfectly, reliably regular, say, arriving exactly every 28 days, that heavily implies her hormonal clock is functioning perfectly.
So the problem is just physical.
The problem is structural. The fibroid is a physical mass in the uterine wall that bleeds excessively during a normal hormonal period.
But our patient's cycles are chaotic. 45 days, then 70 days.
That chaos points away from a structural mass and directly at the hypothalamic pituitary ovarian axis, the HPO axis. Let's look at a normal menstrual cycle. In the first half, the ovary produces estrogen, which causes the lining of the uterus to thicken and proliferate.
Okay, building the lining.
Mid-cycle, ovulation occurs, an egg is released. The remnant of that follicle then starts producing progesterone.
What does the progesterone do?
It acts as the stabilizer. It stops the lining from growing thicker and matures it, getting it ready for a fertilized egg. If there is no pregnancy, the progesterone levels drop, the support beams are removed, and the lining sheds cleanly and predictably. That is a normal period.
So what happens in our patient who isn't ovulating?
If there is no ovulation, there's no progesterone, ever. The estrogen just keeps pumping, unopposed. The uterine lining keeps building thicker and thicker, like a skyscraper being built without any steel support beams.
That sounds unstable.
It is. Eventually, the lining becomes so massive and unstable that it simply cannot hold itself up anymore, and it randomly begins to collapse and slob off. This causes heavy, chaotic, completely unpredictable bleeding. In a 24-year-old, this is often due to an immature HPO axis or polycystic ovary syndrome.
So the irregular timing is the loud alarm bell for hormones. Here's another metabolic trick, this time in the ER with a diabetic patient. An elderly man with a long history of type 2 diabetes is brought in by ambulance in a state of profound confusion, muttering nonsensically.
Another altered mental status case.
His lab work comes back, and his blood glucose is a staggering 890 milli-GDL. When I hear diabetic with massive blood sugar and altered mental state, my brain immediately jumps to diabetic ketoacidosis, DKA.
Sure, DKA is famous.
But the labs show absolutely zero ketones in his blood or urine. The diagnosis is hyperosmolar hyperglycemic state, HHS. Why does a type 1 diabetic go into acid-filled DKA, but this type 2 diabetic with a sugar of nearly 900 doesn't?
This is a beautiful illustration of how insulin actually works in the body. Everyone knows insulin's primary job, right?
Hmm.
It acts as the key to unlock cell doors, allowing glucose to move from the blood into the muscle and fat cells.
Yeah, that's what we're all taught.
But insulin has a second, equally vital job. It violently suppresses lipolysis, the breakdown of fat stores.
Okay, so insulin tells the fat cells, hold on to your fat, we don't need it right now.
Right, let's look at type 1 diabetes first. In type 1, the pancreas has been destroyed by the immune system. There is absolute zero insulin in the body. Because there is no insulin, glucose can't enter the cells, so blood sugar rises. But crucially, because there is zero insulin, the brakes on the fat cells are completely removed.
The body thinks it's starving.
Exactly. The body thinks it is starving, so it massively breaks down fat into fatty acids. The liver rapidly converts these fatty acids into acidic ketones for emergency fuel. The blood turns acidic. That is diabetic ketoacidosis.
But our patient has type 2 diabetes?
In type 2 diabetes, the pancreas is still working, but the body cells have become resistant to the insulin. It takes a huge amount of insulin to force the glucose into the resistant cells. Eventually, the pancreas falls behind, and the blood sugar skyrockets to 8890.
So why no ketones?
Here's the physiological trick. It takes far, far less insulin to suppress fat breakdown than it does move glucose. So that tiny, struggling trickle of insulin still being produced by the type 2 pancreas is more than enough to keep the brakes on the fat cells.
No fat breakdown means no ketones, no acid.
Exactly. But he is still profoundly confused. Why? Because a blood sugar of 890 turns the blood into a thick, hyperosmolar syrup. Through the simple physics of osmosis, that thick, sugary blood physically draws water out of the surrounding tissues to dilute itself.
Wait, really? It pulls water out of the tissues?
It literally sucks the water out of the brain cells. The neurons dehydrate and shrink, causing profound neurological dysfunction and coma. That is the hyperosmolar hyperglycemic state.
The brain is basically turning into a raisin. That is terrifying, but the mechanism is fascinating. Let's look at one more masquerader. A 28-year-old woman goes to her doctor because her periods have completely stopped amenorrhea, and she has noticed a milky discharge from her breast colectoria.
This one is a great puzzle.
Now, if a woman isn't pregnant, but is lactating and missing periods, you assume it's a primary problem with her ovaries, or maybe a pituitary tumor secreting prolactin. But the lab tests revealed a true diagnosis: severe primary hypothyroidism. Her thyroid gland is failing. How on earth does a sluggish thyroid in her neck make her lactate and stop her periods?
It is a masterclass in the unintended consequences of hormonal feedback loops. The endocrine system operates on a strict chain of command. The thyroid gland in the neck produces thyroid hormone, but it only does this when ordered to by the pituitary gland in the brain.
Okay, there's a boss.
And the pituitary only gives orders when stimulated by the hypothalamus, the master commander of the brain.
So hypothalamus talks to pituitary, pituitary talks to thyroid.
When a patient develops primary hypothyroidism, say from Hashimoto's disease, the thyroid gland is destroyed and stops making thyroid hormone. The hypothalamus senses this drop in blood hormone levels and goes into a panic. It thinks, the thyroid isn't working, I need to shout louder.
So it turns up the volume.
So the hypothalamus starts pumping out massive quantities of a signaling hormone called TRH, thyrotropin releasing hormone.
TRH goes down to the pituitary to say, whip the thyroid harder.
Exactly. But here's the biological quirk. TRH is not perfectly specific. It stimulates the pituitary cells that control the thyroid, yes. But TRH also acts as a powerful stimulant on the lactotroph cells in the pituitary, the cells that produce prolactin.
Oh, and prolactin is the hormone that stimulates the breast tissue to make milk?
Yes. The massive surge of TRH, intended solely to rescue the failing thyroid, inadvertently causes a massive overproduction of prolactin. The high prolactin levels travel to the breast and cause galactorrhea, the milky discharge.
And what about the missing periods?
Furthermore, prolactin is an evolutionary suppressant of reproduction. It's why women are less likely to get pregnant while actively breastfeeding. Hyperprolactin physically blocks the release of gonadotropins, which shuts down the ovaries and stops the menstrual periods.
That cascade is incredible, so how do you fix it? You don't give her estrogen or breast medication, right?
You give her a simple daily pill of synthetic thyroid hormone, levothyroxine. The thyroid levels in the blood rise back to normal. The hypothalamus relaxes and stops pumping out TRH. The TRH levels fall, the prolactin levels fall, the lactation stops, and the ovaries wake back up. You fix a reproductive complaint by treating the neck.
Those metabolic tricks are tough enough with an adult who can clearly articulate their symptoms and history. But what about patients who can't speak for themselves at all? Or situations where the medical logic collides with human ethics? Let's move to our final section. Vulnerable populations, pediatrics, obstetrics, and ethics.
These scenarios test a completely different mental muscle. You aren't just managing biochemistry anymore. You are managing terrified families, developmental milestones, and rigid ethical frameworks.
Let's start with a terrifying pediatric case. Parents rush their 4-month-old infant into the ER. The baby has severe muscle weakness, they aren't feeding, their eyelids are drooping, and their cry is just a weak whimper. It's the classic floppy baby presentation.
Always a high alert situation.
The attending suspects infant botulism. The sources know that this diagnosis is confirmed using a repetitive nerve stimulation test. Walk me through this. Why does shocking a nerve over and over prove it's botulism?
Infant botulism usually happens when a baby ingests the microscopic spores of Clostridium botulinum, often classically linked to a parent putting raw honey on a pacifier. The infant's gut doesn't have the normal bacterial flora to fight off the spores, so they colonize the intestines and start pumping out botulinum toxin into the blood.
And what does the toxin do to the muscles?
To understand that, we look at the neuromuscular junction. This is the microscopic gap between the end of a nerve and the muscle it controls. For a muscle to contract, the nerve has to release thousands of tiny chemical ferries, acetylcholine molecules, across the gap to hit the muscle receptors on the other side.
The nerve throws the acetylcholine, the muscle catches it and flexes.
Botulinum toxin is a presynaptic blockade. It physically attacks the nerve ending itself, destroying the cellular machinery needed to release the acetylcholine ferries. The nerve wants to fire, but the exits are barricaded. The muscle never gets the signal, resulting in profound, flaccid paralysis.
So how does the shock test prove this?
Now, to prove this is the cause, a neurologist does a repetitive nerve stimulation test. They place electrodes on the baby and send a rapid, high-frequency series of electrical shocks down the nerve.
Over and over, really fast.
Because the blockade is presynaptic, the rapid, repetitive electrical shocks force the nerve ending to push harder and harder against the barricade. It's like a crowd of people repeatedly slamming into a jammed exit door. With each successive shock, a tiny bit more acetylcholine manages to squeeze through the blockade.
Wait, so the signal actually gets stronger?
Yes. On the monitor, the electrical response of the muscle actually grows larger with each subsequent shock. This is called an incremental response. It is the absolute hallmark of a presynaptic disease like botulism.
What if it was a different disease?
If the problem were postsynaptic like myasthenia gravis, where the muscle receptors themselves are broken, the muscle would just get tired, and the response would shrink over time.
The pattern of the electricity reveals exactly where the cellular barricade is. That is so elegant. Let's look at a completely different pediatric challenge. A 13-year-old boy is brought to his pediatrician. His weight is in the 97th percentile, while his height is in the 10th. His parents are frustrated.
A very common, very sensitive situation.
They tell the doctor they've talked to him about eating better and exercising, but he just plays video games. The boy sits there quietly. His grades have plummeted. He quit the school band, and he admits he is being severely bullied at school because of his weight.
That's heartbreaking.
The board question asked for the most appropriate management approach. The wrong answers include handing the boy a strict diet pamphlet, immediately prescribing a weight loss medication, or starting him on solo cognitive behavioral therapy. The correct answer focuses entirely on involving the parents in the treatment and scheduling regular family follow-ups. Why is the medical focus on the parents, not the patient?
Because a 13-year-old is a product of their environment, and they have almost zero control over it.
Right.
A 13-year-old does not buy the groceries, they don't cook the family dinners, and they don't control the schedule that might prioritize fast food over a home-cooked meal.
Right.
Adolescence is a time of intense vulnerability. The bullying is clearly causing depressive symptoms, hence the drop in grades and social withdrawal. But treating pediatric obesity by placing the entire burden of behavioral change squarely on the shoulders of a depressed child is a recipe for catastrophic failure.
Like, here's a diet sheet, kid. Try harder. It just adds to the shame.
Exactly. It reinforces the stigma. The environment is the root driver of the pathology. Therefore, family-based intervention is the scientifically proven standard of care. It means sitting the parents down and explaining that they need to change the home environment.
It's a family effort.
They need to remove the high-calorie snacks from the pantry. They need to initiate family walks after dinner. They need to model healthy eating themselves without making the child feel targeted or punished. You treat the family ecosystem, which gives the child a safe environment to naturally achieve a healthier weight.
It's recognizing the limits of a child's autonomy. Here's a quicker pediatric case, but a very scary one for parents. A 5-year-old boy wakes up with a sudden limp and complains his hip hurts. He had a runny nose and a mild cough a week ago, but was otherwise fine.
Parents always panic with hip pain.
And the parents are terrified it's a surgical emergency, like a severe joint infection. But the doctor checks the child's blood for inflammatory markers, specifically CRP and ESR. The markers are completely normal. The diagnosis is transient synovitis. First, what are CRP and ESR, and what is this disease?
CRP is C-reactive protein, and ESR is erythrocyte sedimentation rate. These are nonspecific blood tests that act as the body's generalized fire alarms. If there's a massive, severe bacterial infection or intense systemic inflammation anywhere in the body, these numbers shoot through the roof.
But the boy's numbers are normal.
Right. And he doesn't have a high fever. That allows the doctor to confidently rule out septic arthritis, which is a terrifying bacterial infection inside the joint capsule that can physically destroy the cartilage in a matter of hours, requiring emergency surgery.
So what is transient synovitis?
By ruling that out, we are left with transient synovitis. This is a very common, benign, temporary inflammation of the synovial lining of the hip joint. It very frequently occurs a week or two after a child fights off a mild viral upper respiratory infection.
So his immune system ramped up to fight the cold, won the battle, but accidentally inflamed his hip joint on the way down.
That's the running theory, a reactive inflammation. The treatment is simply ibuprofen for the pain and reassuring the terrified parents that their child will be running normally again in 5 days. Knowing when not to panic and when not to cut is a crucial board skill.
Speaking of upper respiratory infections, the outline notes another pediatric scenario that doctors face daily. A mother brings her 4-year-old in with a runny nose, a low-grade fever, and a cough that's lasted 4 days. The mother is exhausted and demands a prescription for amoxicillin and antibiotic to knock it out.
Oh, the classic antibiotic demand.
The doctor refuses, explaining it's a self-limiting viral URI. Why is it so important that the USMLE tests doctors on their ability to say no to parents?
Because antibiotic stewardship is a global public health crisis. The vast majority of pediatric upper respiratory infections are caused by viruses, rhinovirus, adenovirus, RSV. Antibiotics only kill bacteria. They do absolutely nothing to a virus.
But parents just want to feel like they're doing something.
And that's the danger. If a doctor caves to the mother's pressure and prescribes amoxicillin, the child gains zero benefit but suffers the risks of allergic reactions and diarrhea. More importantly, exposing the normal, healthy bacteria in that child's gut to unnecessary antibiotics allows the strongest bacteria to mutate and survive, creating drug-resistant superbugs. The USMLE tests the doctor's communication skills. Can you empathetically educate a tired parent without compromising evidence-based medicine?
Okay, one more pediatric anatomical quirk. A newborn baby is brought in for a checkup, and the parents point out a bulge near the baby's belly button. It pops out when the baby cries, but it's soft and easily pushed back in. It's an umbilical hernia.
Very common.
The parents want to know when the surgeon is going to fix it. The USMLE answer is observation, as it will likely close spontaneously. Why wait? Doesn't a hernia mean a hole in the muscle wall?
It does. An umbilical hernia is a defect in the linea alba, the connective tissue between the abdominal muscles, right where the umbilical cord used to be. But unlike adult hernias, which almost always require surgery because they can trap and strangulate loops of bowel, congenital umbilical hernias in infants behave differently.
How so?
As the child grows, walks, and develops their core abdominal muscles, those muscles naturally pull together and close the defect entirely on their own in about 90% of cases by age 5. Surgery is only indicated if the hernia is massive or if it hasn't closed by the time they reach school age. Again, it's the art of doing nothing intelligently.
Let's shift from pediatrics to obstetrics, caring for the mother before the baby even arrives. A woman comes to the clinic for her very first prenatal visit. She's 12 weeks pregnant. Her medical history is unremarkable, but her body mass index, her BMI, is 32.
Okay, high BMI.
The standard of care protocol says she should be given an early glucose tolerance test to screen for diabetes. But wait, don't pregnant women usually drink that awful sugary drink and get tested for gestational diabetes much later, like at 24 or 28 weeks? Why are we testing her at 12 weeks?
You are correct about the timeline for gestational diabetes. Gestational diabetes occurs because the placenta produces hormones like human placental lactogen, which actively cause insulin resistance in the mother.
Right.
That placental hormone production doesn't peak until the late second and early third trimesters, which is why the universal screening happens at 24 to 28 weeks.
So why test this specific patient at 12 weeks, before the placenta is really up and running?
Because of her BMI. A BMI of 32 puts her in the obese category,
Right.
which is a massive risk factor for standard type 2 diabetes. The doctor is not looking for gestational diabetes caused by the pregnancy. The doctor is checking to see if this woman already had undiagnosed type 2 diabetes before she ever conceived.
Ah, and why does that timing matter so much to the fetus?
Because the first trimester is when organogenesis occurs. The baby's heart, brain, and spine are literally being assembled. If the mother has unrecognized type 2 diabetes, her blood sugar is chronically high. That sugar crosses the placenta, bathing the developing embryo in a toxic, hyperglycemic environment.
That sounds incredibly dangerous.
It severely increases the risk of catastrophic congenital anomalies, like heart defects or neural tube defects. Finding out she is diabetic at 28 weeks is too late to prevent those structural defects. You test early in high-risk women to gain control of the sugar immediately.
Another critical OB scenario. A woman is rushed to labor and delivery. She is having regular contractions and her cervix is dilating. The problem, she's only at 27 weeks gestation. That is incredibly premature.
Extremely early.
The medical team works to slow the labor, but they also give her an intramuscular injection of betamethasone, a powerful corticosteroid. What does a steroid shot in the mother's arm do for a premature baby?
It is arguably one of the most life-saving interventions in modern obstetrics. At 27 weeks, a fetus's organs are still deeply underdeveloped, particularly the lungs. The tiny air sacs in the lungs, the alveoli, require a slippery, soapy substance called surfactant to stay open.
I've heard surfactant described like trying to blow up a wet balloon. If it's just wet rubber, the sides stick together and it takes immense force to blow it up. Surfactant is like coating the inside of the balloon with soap so it inflates easily.
That is exactly the physics of
Yeah.
it. Without surfactant, every time the premature baby exhales, the tiny air sacs collapse and stick together. The baby quickly exhausts itself trying to pry them open with the next breath, leading to lethal respiratory distress syndrome. Fetuses don't naturally produce enough surfactant until much closer to full term.
And the steroid shot triggers it.
Yes. Betamethasone crosses the placenta, enters the fetal bloodstream, and acts as a massive stress signal to the fetal lungs. It chemically forces the lungs to rapidly accelerate their maturation and start pumping out surfactant immediately. If you can delay delivery for just 48 hours after giving those steroid shots, the baby's chance of surviving without severe lung damage increases exponentially.
Let's jump ahead to after the birth. A woman who had a prolonged, difficult labor and an emergency C-section develops a high fever 2 days postpartum. Her uterus is extremely tender to the touch, and there is a foul-smelling vaginal discharge. This is postpartum endometritis, a severe infection of the uterine lining.
A very serious complication.
The treatment listed is a combination of broad-spectrum intravenous antibiotics like clindamycin and gentamicin. My question is, if we know it's a uterine infection, why use a broad-spectrum carpet bomb approach? Why not swab it, find the specific bug, and use a targeted antibiotic?
Because postpartum endometritis is almost never a single bug. It is a polymicrobial infection. The human birth canal is naturally colonized by dozens of different types of bacteria. Normally, they are harmless.
But birth changes things.
Right. During a long labor with multiple cervical checks, or especially during a surgical C-section, a mixture of aerobic bacteria, which need oxygen, and anaerobic bacteria, which thrive without it, can be pushed up into the sterile uterine cavity.
And the raw bleeding inside of the uterus after the placenta detaches is the perfect breeding ground.
Exactly. If you try to target just one bug, the other 5 types of bacteria will continue to multiply, spread into the bloodstream, and cause lethal sepsis. You must empirically cover the entire spectrum of likely invaders from minute 1. Clindamycin wipes out the anaerobes, and gentamicin handles the dangerous gram-negative aerobes.
Okay, let's shift to a very common, highly distressing issue for new mothers. A woman is 2 weeks postpartum and comes to the lactation clinic in tears. She says breastfeeding is agonizingly painful. Her nipples are red and inflamed, but there is no fever, no pus, and no severe cracking.
This happens all the time.
The absolute priority recommendation isn't a prescription numbing cream, it isn't an antibiotic, and it certainly isn't to just stop and switch to formula. The answer is simply, observe and reposition the infant's latch. Why is the medical answer just to change the way she holds the baby?
This is a major public health issue because severe pain is the #1 reason women prematurely abandon breastfeeding. losing the massive nutritional and immunological benefits for the infant. The vast majority of early postpartum nipple pain is not a medical infection like mastitis. It is a pure mechanical injury.
A friction burn.
Precisely. The infant has a hard palate, the bony roof of the mouth. If the baby's lash is shallow, meaning they are only sucking on the very tip of the nipple, that sensitive tissue is being violently compressed against the baby's hard palate dozens of times a minute. It causes excruciating pain and tissue breakdown.
So how does repositioning fix the mechanics?
An optimal latch is deep. The baby needs to take a large portion of the lower areola into their mouth. When the latch is deep, the nipple is drawn far back into the soft palate of the baby's mouth, where there's no friction. The baby's tongue does the work of extracting the milk by compressing the milk sinuses under the areola, not by chewing on the nipple. Numbing creams just mask the pain of the tissue being destroyed. Correcting the mechanical latch permanently solves the root cause.
Fix the mechanics, solve the problem. Okay, we have reached the final frontier of the USMLE, ethics and protocols. This is where the test evaluates whether you can maintain your moral compass when the clinical desire for data or the rigid hospital rules push you in the wrong direction.
Medical ethics isn't just philosophy. It dictates the boundaries of what is legally and humanely permissible in practice.
Here is a stark scenario from the sources. A prestigious research team wants to conduct a randomized, double-blind study on a brand-new experimental treatment for bacterial meningitis. To prove the drug works perfectly, their study design includes a placebo control group.
And this is where they fail.
The board question asks about the ethical viability of the study design, and the answer is an absolute hard no. It is a severe ethical violation. Let me play devil's advocate. Don't we need placebo groups for pure, clean science? How else do we know if the new drug actually works?
We absolutely need placebos. When we are testing a drug for a condition that has no current cure, or when we are testing something benign like a mild headache pill, the placebo proves the drug works better than nothing. But bacterial meningitis is a rapidly progressive, devastating infection of the brain and spinal cord lining. Left untreated, it is almost universally fatal, or leaves the patient with profound brain damage and deafness.
And we already have drugs that cure it.
Exactly. We have highly effective standard of care intravenous antibiotics that save lives. The supreme ethical pillar of medicine is non-maleficence, do no harm. If you place a patient with suspected bacterial meningitis into the placebo arm of your trial, you are actively denying them a known life-saving cure and giving them a sugar pill instead.
You are watching them die for the sake of a clean spreadsheet.
It is completely unethical. If you want to test a new meningitis drug, you must perform a non-inferiority trial. You give Group A the current best antibiotic, and you give Group B your experimental drug. You compare the new drug against the standard of care, never against nothing.
Which brings up the oversight of these rules, the IRB, the Institutional Review Board. Another source mentions an ER trauma doctor who wants to test a new, unapproved synthetic plasma expander fluid on critically injured, bleeding trauma patients. These patients are unconscious, crashing, and obviously cannot give informed consent.
Right, emergency medicine research.
The next required step is apply to the IRB for a waiver of consent. Why can't the doctor just use emergency privilege to save their lives?
History is stained with horrific abuses in the name of medical research, the Tuskegee syphilis study being one of the most infamous. Society realized we cannot trust individual researchers, no matter how well-intentioned, to police their own ethics. The IRB is an independent, multidisciplinary committee that exists solely to protect the rights and welfare of human subjects.
But the patients are bleeding to death.
And that makes them the ultimate vulnerable population. They cannot advocate for themselves. In emergency research, obtaining standard-informed consent is physically impossible. The IRB must rigorously review the doctor's protocol. They have to decide. Is the potential life-saving benefit of this experimental fluid truly worth waiving the patient's fundamental human right to consent? They establish strict safety checkpoints and community consultation protocols before a single drop of that fluid is infused. You cannot just play cowboy in the trauma bay.
You have to respect the human right to autonomy, even when they are unconscious. Okay, our final specific scenario from the sources, and I think it is the most brilliant test of clinical judgment versus rigid hospital rules.
I know exactly which one you mean.
A 77-year-old man had major abdominal surgery for colon cancer yesterday. During the surgery, he lost 500 milliliters of blood. Now he's in the recovery room. The nurses note that his urine output has dropped to nearly zero. He has oliguria. His oxygen saturation is hovering at a dangerous 89%.
He's not doing well.
They draw his blood, and his hemoglobin level, the protein that carries oxygen, is 8.00 GDL. Normal for a man is around 14. Now, the strict hospital protocol, the standard rule taught in every textbook, says you only order a blood transfusion of packed red blood cells if the hemoglobin drops below 7.0. But the correct board answer is to transfuse him immediately. Wait, the rule says 7, his number is 8. Why are we breaking the golden rule?
Because this scenario teaches the ultimate lesson of the USMLE and of medicine itself. Treat the patient, not the number. The hemoglobin threshold of 7.0 is a fantastic evidence-based guideline for stable patients. If a 30-year-old patient with an ulcer has a hemoglobin of 7.5, but they're sitting up in bed, eating a turkey sandwich and feeling fine, you hold off on the blood.
Because blood transfusions aren't just giving them water, there are massive risks.
Exactly. Transfusions carry risks of immune reactions, lung injury, and fluid overload. You don't give blood unless you have to. But look at this 77-year-old patient. He is not stable. He is hypoxic. His oxygen saturation is 89%, meaning his tissues are starved for oxygen. And critically, his kidneys have stopped making urine
Why did his kidneys shut down?
because the kidneys are highly sensitive to blood flow and oxygen delivery. When the body doesn't have enough oxygen-carrying hemoglobin, it shunts the remaining blood to the brain and the heart, sacrificing the kidneys. The zero urine output is a screening alarm bell that he's experiencing active end-organ ischemia. His kidneys are actively suffocating and dying.
So his hemoglobin of 8 might look okay on a spreadsheet, but it is completely failing his specific body in this specific moment.
Yes, his metabolic demand is high because he is recovering from major surgery, his heart is old, and he cannot compensate. If you rigidly stare at the protocol binder and refuse to give him blood because the computer says 8 is greater than 7, his kidneys will die today, and he will likely die tomorrow. You must immediately order the packed red blood cells to increase the oxygen-carrying capacity of his blood and reverse the ischemia. The clinical reality of end organ damage supersedes the numerical guideline every single time.
Treat the patient, not the number. I think that perfectly synthesizes this entire deep dive. We started in the murky waters of statistical probability, trying to figure out if our fishing nets were catching boots or fish. We moved through the domino effects of pharmacology, seeing how an over-the-counter painkiller can trigger a triple whammy that destroys an elderly kidney.
We looked at the critical algorithms of diagnostic triage, knowing why an ultrasound is useless on a bone tumor and why you take the bleeding patient to the cath lab before the blood tests even confirm the heart attack.
We unmasked the masqueraders, realizing that a teenager's livery factory was shut down by alcohol, or that a woman's reproductive cycle was frozen by a failing thyroid gland in her neck. And finally, we navigated the incredibly sensitive ethical waters of pediatric autonomy and clinical protocols. It's not about memorizing flashcards. It's about seeing the human body as a continuously communicating web where a change in one corner ripples through the entire system.
The test writers want to ensure that the person wearing the white coat isn't just a biological mechanic, but a dynamic systems thinker.
And I hope for you listening, the next time you read a medical headline or the next time you sit in a doctor's office and they ask you a seemingly random question about your knee pain or your family history, you can appreciate the sheer volume of if-then pathways firing in their brain. They are calculating the number needed to treat, they are verifying the positive predictive value, they are checking for the triple whammy, they are navigating those muddy waters with an incredible framework of logic.
It is a profound responsibility, and the training reflects the weight of it.
But looking at all of this does make me wonder. I mean, we are moving so incredibly fast into the era of artificial intelligence. Right now, today, an AI algorithm can instantly calculate the absolute risk reduction of 1,000 studies in a millisecond. An AI can scan a complex medication list and instantly flag a triple whammy drug interaction before the doctor even finishes typing. It won't forget the hemoglobin protocol, and it can easily be programmed to cross-reference a dropping urine output with end organ ischemia.
The machines are getting exceptionally good at the diagnostic algorithms of medicine.
So if a machine can eventually hold all these physiological pathways, all these pediatric milestones, and all these triage steps perfectly in its memory without ever getting tired, what will the USMLE of the year 2050 look like? If the AI can instantly tell us the next best step in management, will the board exams of the future have to evolve? Will they stop testing rote pathways and start testing human empathy? Will they test the ethical negotiation of convincing a terrified family to change their environment, or the delicate art of sitting with a patient when the algorithm itself simply says, diagnosis uncertain? Will the doctor of the future need to be less of a human calculator and more of a human guide through the wilderness of illness? It's something to ponder as the X-ray machine of medicine gets upgraded once again. Thanks for joining us on this deep dive.